an interesting subspecialty. Cataract always interesting, and most of the ophthalmologists are interested to attend the sessions of cataract. Is it okay to start, Dina, or still? Dina from Mar Vision?
Yes, doctor, please proceed.
Can we start now?
Yes, doctor, please.
Is Dr. Mohammed Hisham will join or not yet?
Not yet, doctor.
Okay, so just to know if he, maybe he will give his talk or not. Okay. So we will start now this interesting session of cataract surgery in extreme eyes. Good evening, everybody. First of all, welcome everybody, welcome our eminent speakers, and welcomes also the participants from everywhere. And we invite Dr. David Chang from California to give the first talk. I will not give the title, I will leave him to give the title. It is very long title, better to he himself to explain it. Please, Dr. David Chang.
All right. Well, good evening from California. It's nice to be joining with you here. I'm going to show one case to illustrate an extremely hard cataract and the approach, but it's a case that has multiple other problems. So I am a consultant for J&J, but nothing specific to this case. You know, rock hard lenses are challenging, but they're challenging because often there are other problems. They typically have weak zonules just from the weight of the lens. Frequently, there's a small pupil. Sometimes the chamber has become very shallow, particularly because the lens is so sizable. There's often been prior surgery, and so there may be other ocular comorbidities, such as with the fundus. So this is one such case. It's a patient who has had in this left eye angle closure glaucoma, and it's been assumed that, you know, he's lost some vision because of that. And so no one's been interested in removing the cataract. He has one good eye, but this is the left eye that I'm showing you. You can see there's sort of stromal atrophy consistent with acute angle closure glaucoma. The pupil doesn't dilate. But this is what's unique. This is the good eye, and it's easier to photograph the fact that there's virtually no anterior chamber. So this is something we occasionally see. It's not common, but you look here and there is almost no anterior chamber. And just imagine now we have this rock hard lens. So what is the approach in a case like this? Well, we went ahead and really wanted surgery. So the minute I put in just a little bit of viscoelastic, the eye is rock hard. So the technique that I would use here, if the eye's not too soft, is a pars plana sclerotomy. And I go 3 millimeters back. I use a disposable MVR blade. I aim posterior toward the optic nerve. And I'm going to then do a limited vitreous tap, I call it. It's basically a small gauge vitrector. And I just take out a little bit of vitreous. Now, I don't want to make the eye too soft, so I kind of palpate the eye, and when it's starting to just get a little soft, I can stop and now fill the anterior chamber, and now I can see the lens and the iris go backward, and I have normal depth. Now the second challenge is we don't have just posterior synechii. The iris stroma has been adherent to the lens because the lens is so forward. So when I go in with the spatula, look at the bottom of your screen, you will see that it's very transparent. You see the spatula through the iris? That's how atrophic it is. So this is going to tear very, very easily. And that's why I'm going to not use iris retractors. I'm going to instead use a Malyugin ring because I think that while the case is going on, it's less likely that the pupil gets stretched any further. I do have to do this very carefully now because when I put that last corner and it will stretch the pupil, as you'll see here. But the advantage of the Malyugin ring, unlike the iris hooks, is the pupil will not get further stretched inadvertently during the surgery. Now I have no red reflex, so this is the point at which now the pupil's larger. I can put in my trypan blue dye, try to get right up against the capsule, a little bit just under the pupillary margin, because, pearl number one is we have to be able to see. And I'm going to use, of course, a dispersive viscoelastic here. So the capsulorhexis is when you start to assess the zonular stability. And I see a little bit of movement, but it doesn't look too bad. So I'm just carefully going to try to make the rhexis large enough, but remember again that I want to have it intact. And this would have been very difficult had I not deepened the chamber. The other problem, of course, is if I had not deepened the chamber, we'd have a tremendous amount of endothelial cell loss with trying to do phaco. And essentially, it would be like an anterior chamber phaco. So after the rhexis is complete, we'll do the hydrodissection, and then we always spin the nucleus. And this is the problem that we're going to have here. I cannot turn this nucleus. Now, I know the lens is large, but you usually can turn the lens, especially if it's dense. And if it isn't turning, you have to suspect weak zonules, that there's not enough peripheral countertraction on the capsule and zonules to turn it. So what should I do? I guess I can start to debulk the lens a little bit and maybe try to hydrodissect again and try to turn it again. But if you force it, you can create a zonular dialysis very easily. So my strategy is actually going to be to, at some point, put in capsule retractors to give me the peripheral and the capsular stability and countertraction. Sometimes you use two instruments to try to turn the lens, but it is not a turning. So I know that with a dense lens like this, the zonules are usually weak. It's a question of how much. And so I'm going to put in capsule retractors, and there are many different kinds. I'm trying to hydrodissect again, but I'm going to use, we get ours from Microsurgical Technologies, and it's a double-stranded loop, and it gives support peripherally to the fornix of the capsular bag. I'm going to put 3 of these in, and think of it as artificial zonules that holds and supports the lens in the axial direction, the AP direction. It keeps the peripheral capsule a little more taut, but also it anchors it. So now, instead of wanting to turn with the lens, the capsular bag is fixed to the sclera. And now, with 2 instruments especially, I can pivot on the phaco tip. I can finally turn it. Now, I have done a half of a trough. I've sculpted half of a trough. And with a dense lens, that's deep enough now to get an anchor with my phaco tip. And this is the Sharp Chang vertical chopper. And so I'm using my central trench to get very deep. I'm lifting a little bit with the phaco tip using high vacuum. And this has a sharp point on it. And I'm incising the nucleus, while at the same time I slightly lift the fragment with the phaco tip. And this creates this shearing motion that can, in this case, transmit all the way to the back of the lens. But the key is I did a half of a trench, just like I was sculpting, but I did not complete the trench. And once I rotated 180 degrees, it meant that I could get the phaco tip deep enough. Now remember, this lens is so large, it's like the equivalent of maybe 3 normal nuclei in terms of the volume. So you will see me frequently pause and recoat the endothelium with the dispersive viscoelastic. This happens to be Healon Endocoat. And now I have switched from my vertical chopper to a horizontal chopper, because when I get these little pieces here, I make them smaller and smaller. And if you have non-longitudinal ultrasound like OSL or ellipse, this is when you want to use it with these fragments. The other thing is I'm going to try to really be slower than normal when I get these pieces. There's a tendency to relax and then to use a lot of ultrasound to make it go faster. But this is the point where you get the endothelial cell loss, in my opinion, because if you go too fast, the pieces are too large, they bounce away from the phaco tip. And notice again, I'm going to recoat the endothelium. Now, notice here I'm going underneath the nucleus. That's important because as more of the posterior capsule is exposed, remember the zonules are weak, and that posterior capsule is not as taut as it normally is. So this viscoelastic vault is not only pushing the capsule away, but it's stretching the capsular bag. And I'm putting the chopper underneath. It's stretching the capsular bag so it won't come up to the phaco tip. Notice how with just this last little piece, this is still when you can aspirate the posterior capsule. So I paused and I totally, again, put dispersive in, which resists aspiration to stretch the capsular bag, and to then put it on stretch to essentially take the place of the zonules normally putting the capsular bag on stretch. So the INA is easier because I have not put in the CTR. And if you can, try to use the capsule retractors and then delay the CTR until the cortex has been removed so it won't be trapped. Notice I aim to the left so that it opens to my right. And you notice that I left the capsule retractors in until after the CTR has been put in. That's because just inserting the CTR causes some lateral displacement of the capsular bag, and the CTR is really there to prevent the capsular bag from being displaced. I'm just using a three-piece monofocal. You could also do a single-piece design, but I like the three-piece because the haptics also provide some stretch along with the CTR. And you don't have to be quite as compulsive as me, but I like to make the rhexis diameter a little bit larger because it will contract with weak zonules, even with the CTR. And you can see that with the Malyugin ring, I can expose this area without just making the pupil wider. I'm actually moving the pupil. And now when I remove this, let's look at the iris stroma, and you can see how this is sort of the most gentle way, I think, to open things up. And then finally we remove, and I use the cohesive here because it's just easier to remove. But we'll close the sclerotomy with a single 8-0 vicryl suture, and then we have finished the case. So the key here was that vitreous tap. Now, naturally, there's a little bit of corneal edema, but the cornea is here at 1 week. You can see just how crystal clear and compact this is, despite the very narrow angles, the small pupil, the zonulopathy, and that extremely shallow chamber. So all of these techniques combine to provide a good cornea. Now, surprisingly, even though there was some field depression and optic neuropathy, this eye got to 20/30 plus after being, basically given up for dead. And because of the anisometropia and the cataract in the other eye, the patient had surgery. And then I did exactly the same thing with the vitreous tap to deepen the chamber, and we did well. So again, this is the principles. Now, when you have a rock hard lens, it's all about protecting the endothelium. So let's just review what we did. You could have done an extra cap, but then you have the little bit of the risk of suprachoroidal hemorrhage. We did the vitreous tap, multiple applications of OVD, the vertical and horizontal chopping, and then the viscoelastic at the end. My last slide, this is my paper presenting 4 cases. For the first report of this was in 2001, and I presented at the 2000 ASCRS meeting this technique of doing the vitreous tap. And it's important not to aim toward the lens. You must aim posterior. It's important not to make the eye too soft. And you only need to remove just a little bit. But because you're using the vitrector rather than the needle, you're not going to end up, putting too much traction on the vitreous and causing a retinal tear. And you don't want to do this if the axial length is lower than 20. So a non-ophthalmic eye, you don't know where the pars plana ends. But if you have an eye that's 20 or above, so most of these eyes are 21, you can safely go back 3 millimeters to do this. And it's not often, but it's a lifesaver when you do this technique. So thank you very much. Dr. Willem, I think you're on mute.
Thank you very much, Dr. David. It's a nice presentation. I would like to ask you, would you implant a 3-piece lens in the sulcus and do the optic capture? I learned myself this technique from you instead of just to ensure better centration on the long term.
Yes, I think that's a really good question. So the question is, if you have zonulopathy, the CTR by itself won't help you. And I think in this case, I felt it was okay. But if you have any question or significant zonulopathy, a 3-piece in the sulcus gives you additional 2-point fixation where the haptics are touching the ciliary body, especially if you orient the lens from the 3 o'clock to 9 o'clock position. That's when we have our lateral saccades. And if you try that, you'll be really impressed with the stability. I then capture the optic with the CCC. That prevents contracture. It centers the lens, and it prevents it from rotating, because often you may have a zonular dialysis that is occult, and then you don't have to change the IOL power. So thank you for mentioning that.
Thank you very much.
Thank you very much, Dr. David. And thank you, Dr. Ahmed, for your comments. I hope that we'll have time at the end to have interesting discussion, because all the interesting cases needs discussion. So now I can see Dr. Yuri and Dr. Muhammad Hisham, they joined us. Welcome.
Everyone.
Very good. So we have the full speakers and panelists. Now, Dr. Ali Hafiz will give the second talk of cataract extraction in angle closure glaucoma. Dr. Ali Hafiz from Canada. Please, Dr. Ali.
Yes, thank you. Okay, can you see my screen?
Yes.
Okay, thank you again for the invitation. I'm going to be speaking today about cataract extraction in angle closure glaucoma, or rather cataract extraction as a treatment for angle closure glaucoma. I'm a glaucoma specialist, so I have no financial disclosure. And during the coming 15 minutes, I'm going to try to answer these 4 questions. Does cataract extraction help in resolving a residual angle closure after laser peripheral iridotomy? Second question would be, do we obtain a better outcome if this cataract extraction is combined with goniosyneculysis? The third would be, do we obtain a better outcome if cataract extraction is combined with endocyclophotocoagulation? And the fourth would be, how about clear lens extraction? Are we there yet? So a little bit of a background. Angle closure glaucoma, we know, is the less prevalent type of glaucoma compared to the open angle glaucoma, but its contribution to vision loss and blindness is equally significant. 0.6% of the general population has it, with 6 to 9% of patients of glaucoma and an increased incidence of 55 years or old. So it tends to coexist with cataract, and sometimes we have the two problems presenting at within the same patient. Eyes at increased risk for primary angle closure glaucoma show a decreased axial length. So they're by nature smaller eyes with a proportionately larger lens. The iris lens diaphragm is anteriorly situated, giving us a small anterior chamber depth and resulting in a narrow filtration angle. Pupillary block has been demonstrated time and again as the main mechanism of outflow obstruction in angle closure. But we now know that there are other non-pupillary block mechanisms that can play a major role. Plateau iris configuration, peripheral iris crowding, as well as anterior lens positioning, or what we tend to call a high lens vault. So for years and years, we've been doing laser peripheral iridotomy to relieve the pupillary block, widen the angle, and bring down the pressure. And studies have shown that this can be effective. 100% of patients had resolution of an acute attack after laser peripheral iridotomy. But the problem is that 6 months after that laser iridotomy, 58% of these patients developed elevated intraocular pressure, and 33% of them needed trabeculectomy. So that would be a problem. Even in chronic cases of angle closure, patients with narrow angles after laser peripheral iridotomy were found to have up to 180 degrees of peripheral anterior synechia, causing recurrent elevations of intraocular pressure. And that elevation of intraocular pressure has been correlated to the amount of peripheral anterior synechia. So PAS is a problem. The second problem would be the plateau iris configuration. Patients with narrow angles, again after laser peripheral iridotomy, were found to have a high incidence of plateau iris configuration as demonstrated by UBM. And these patients tended to show a high positive response when subjected to the darkroom prone position test. So in short, there are forces acting on three anatomic levels, and they can predispose to angle closure glaucoma. At the level of the iris pupillary block, at the level of the ciliary body plateau iris, and at the level of the lens, high lens vault. Elimination of pupillary block by the iridotomy does not eliminate the impact of the other two forces. And this is where cataract surgery comes in. It relieves the anterior chamber crowding. It helps deepening of the anterior chamber and widening of the angle, and thus improves the facility of outflow of aqueous humor and decreases intraocular pressure and variations of intraocular pressure. Studies have shown that cataract surgery subsequent to laser peripheral iridotomy was effective in reduction of intraocular pressure and resolution of angle closure. As well, here another study from Japan showed a reduced intraocular pressure of 30% and a reduced number of glaucoma meds by 1 in angle closure glaucoma patients with a survival analysis of 92%. So there are people who would even propose that cataract surgery should be considered as the first option for treatment in a coexisting cataract and angle closure glaucoma. This is a video courtesy of my colleague, Dr. Ike Ahmed, and this is a case of a nanophthalmic eye, which is considered the holy grail for angle closure glaucoma, the extreme of the extreme. And again, like Dr. Chen mentioned, we do. Dr. Chen mentioned we do use we place a 23 gauge trocar through a sclerostomy just to maintain a unicameral eye in such a case. This is the technique that is known as Zoinio zonulohyalodectomy. Capsular access is done and hydrodissection. There is no really vitrectomy at that point. This is a regular cataract surgery, and vitrectomy comes in at a later phase of the procedure after removal of the lens. Now, this is the most important maybe point in the surgery. Whenever an instrument is removed from the eye, care should be taken not to lose the anterior chamber. Cases of nanophthalmus are known for two major problems: exudative or sort of detachments, either hemorrhagic or serous, and the other problem would be aqueous misdirection. So every time an instrument is removed from the eye, a reformation of the anterior chamber should be maintained. The lens is placed and the wound is closed with pylo, and the case completed with no problems. Now, tips for that surgery would be giving intravenous mannitol preoperatively, making sure that you have a long corneal tunnel, being very careful with the capsular access. A large capsular access is needed, but still be careful not to lose it. Low phaco power, remember you're very close to the endothelium, and use adequate viscoelastic use. And in these cases, I tend to use a mix of cohesive and dispersive viscoelastic in a soft shell technique, and above all, avoid flat AC. Now, if you want to supplement that with goniosyncytialysis, so if we're dealing with a case of primary angle closure unresponsive to treatment because of the extensive peripheral anterior synechia, again, direct viscoelastic injection into the angle of the anterior chamber, and then we can either use an iris repositor, or we can use a peeling forceps at 25 gauge to release the peripheral anterior synechia from the angle using a direct gonio lens. The important thing about the technique is to just exert a gentle downwards vertical force on the peripheral anterior synechia. So a downward force rather than a radial force. And that would help separate the synechia without inducing any iridodialysis. Okay, next. And this technique has been shown to be effective in both acute and chronic angle closures. And however, the lower success rate and the higher peripheral anterior synechia reformation were reported in the chronic group. The other would be technique that could be used is the endocyclophotocoagulation. Again, for advanced cases with plateau iris configuration, under viscoelastic injection, diode laser is applied on the posterior part of the ciliary processes until shrinkage is noted. And again, 180 degrees of the circumference is usually treated. Okay, again, that technique has shown success, and the difference between when comparing it to transscleral has shown as an equal effect, though less in terms of complication rate. Final point about clear lens extraction, and when we mention clear lens extraction, we have to mention the EAGLE study, which is a multi-centered study that looked at the effectiveness of early lens extraction for the treatment of primary angle occlusive glaucoma. The study did show that an initial clear lens extraction as the first-line treatment for these cases can be of benefit. And there was a 1 millimeter lower pressure in the lens extraction group, but with 21% of the cases needing further treatment as opposed to 61% in the iridotomy group. And the study as well showed a better cost effectiveness and less need for further procedures. However, the study, as we know, is a multi-centered study with maybe out of the 6 countries involved, 4 of them were Asian countries. So it needs to be kind of applied on other populations before validated. Again, the study is not known if it would work for less advanced cases of glaucoma. And again, longer term follow-up would be needed for monitoring progression. So back to the questions, does cataract extraction help in resolving residual angle closure after laser peripheral iridotomy? Absolutely. However, care should be taken and in terms of the technique, and precautions should be dealt with. Do we obtain a better outcome if it's combined with goniosyneuclitis? Yes, I believe so, especially in acute cases of glaucoma. And we obtain a better outcome if it's combined with endocyclophotocoagulation. Again, yes, and with a markedly less incidence of complications. And when it comes to clear lens extraction, I do not think we are there yet, but further studies will show us the way. Thanks a lot. Thank you very much.
Thank you. Thank you very much, Dr. Ali. As we said, we postponed the discussion according to our time. Now, please, Dr. Ahmed Assaf. Dr. Ahmed Assaf will start his presentation.
Can you, Dr. Ali, can you please stop sharing presentation, please?
Yes, absolutely.
No problem. It was an excellent one, by the way.
Thanks a lot. Thank you very much, Dr. Ahmed. I've stopped sharing.
Okay. Okay, so I'm charged here to talk about the cataract extraction in vitrectomized eye, and I don't have any financial disclosure in any of the subjects mentioned in this presentation. As you know that the incidence of cataract after vitrectomy has been reported to be up to 100% within 2 years after the primary vitrectomy. And the reason of the cataract is not clear so far, but there are some predisposing factors, including advanced age, light toxicity, intraoperative oxidation, and silicone oil, diabetes. But to my mind, I think that the mechanical trauma at the time of the primary vitrectomy, just touching the posterior lens capsule with the vitrector, might be the most important predisposing factor for cataract formation. And so that's why it has been advocated to do primary phaco-vitrectomy, even if the cataract is not that dense, because of the high incidence of cataract. We have, before the surgery, we have some biometrical challenges that include the silicone oil. If the presence of the silicone oil in the posterior segment of the eye, this silicone oil will slow down the ultrasound for biometry. That's why we give a falsely large eye or longer axial lens. So correction factors should be kept in mind. Of course, optical biometry will produce better results, but sometimes we cannot do optical biometry because of the density of the cataract. Another biometrical challenge is the hyperdeep anterior chamber in the vitrectomized eye, especially if these eyes are fluid-filled, and this will cause a wrong assumption of the effective lens position, and that's why we most probably will have biometrical challenges in the term of false calculation of the effective lens position and the IOL power. It has been mentioned that the SRKT formula, which is less affected by the anterior chamber depth, is more or less the most accurate formula that can be used in such context. Another challenge is, which is the IOL consideration. Because of the design of the IOL, because of the refractive index of the silicone oil, which is if planned to be stay for a longer time inside the posterior segment of the eye, With a biconvex lens, the anterior surface of the silicone oil will act as a meniscus lens, and this will cause diversion of the light rays inside the eye in the posterior segment, and this will again add to the difficulty in the measurement of the correct power of the IOL. And the best choice is the convex plano IOLs if it is available in the market or in the area you are working in. Of course, there is high incidence of posterior capsular rupture and weak zonia in these eyes, so that's why we should opt to 3-piece IOL or at least keep the 3-piece IOL as a backup lens in the OR. And of course, we should avoid the silicone IOLs by any means. Regards the intraoperative challenges with this, which is the main part of my talk today, we have many challenges intraoperatively. For example, we have insufficient mydriasis, compromised red reflex that requires sometimes staining, hyper deep anterior chamber, excessive fluctuation of the anterior chamber, and excessive flaccidity of the posterior capsular plaques, and high incidence of posterior capsular rupture, and of course, PCO after the surgery is very high compared to the senile cataract. The hyperdeep anterior chamber is caused by zonial laxity, and it's more pronounced in the fluid-filled eye, not silicone-filled eye, but again, it's present in the silicone-filled eye. And this causes steep angulation of the phaco handpiece during the phacoemulsification, and this will compromise the technique and may necessitate low infusion pressure and low bottle height. Again, because of the same reason and because of the lack of the counter pressure from the vitreous in the posterior segment of the eye, we have excessive fluctuation or trampoline of the anterior chamber during phacoemulsification, and we can go around this by prolapsing the nucleus outside the lens capsule in the anterior chamber to do phacoemulsification, or we can, of course, reduce the bottle height and infusion pressure, or we can use the technology that I'm going to mention in a few minutes. As you can see in this movie, I'm here prolapsing the nucleus after doing a relatively large rhexis. I'm doing phacoemulsification in the anterior chamber to avoid fluctuation in the depths of the anterior chamber. Of course, we should use ample amount of dispersive OVD to protect the corneal epithelium during phacoemulsification. Or we can opt to the technology. I don't have any financial interest. This is the White Star case chamber stability that it's a sort of automatic occlusion sensing mode. Here the machine can sense the occlusion and drops the vacuum instantaneously and automatically to a lower level as if anticipating occlusion break, and once occlusion break occurs at a lower vacuum level, and this improves the stability of the anterior chamber. You can see this is slow motion video. I have preset the vacuum to 420 millimeter mercury, but the machine will drop the vacuum just before occlusion break to 340. This is the my preset level, another vacuum setting. And just once occlusion break occurs at a lower vacuum level, and this minimize the fluctuation of the anterior chamber to a great extent. Again, we can use the technology of the Centurion, which is known as active sentry. The handpiece now it's provided with a sensor that can continuously monitor the IOP inside the anterior chamber and continuously giving information to the motherboard, to the machine. So this the motherboard or the machine will actively infuse fluid inside the anterior chamber, increase or decrease to keep the IOP stable and minimize the fluctuation of the anterior chamber. You can see here, this is the small rectangle bar. It's fluctuating ups and downs. The IOP, that means that the machine is increasing the infusion and decrease the infusion to keep the anterior chamber depth stable as possible by active monitoring the IOP inside the eye, thanks to the sensors provided now within the handpiece of the phaco machine. Again, we have the high incidence of fibrous plaque and hole during phacoemulsification, and this can be sometimes quite difficult to examine or see in the preoperative clinical examination. Probably ultrasound B scan can detect the small break or hole in the posterior capsule, but mostly or usually it presents as intraoperative surprise. That's why we should opt for sometimes to do the posterior rhexis to remove this fibrous plaque or convert this hole, if present, into a more or less posterior capsular rhexis. This is my last slide. This is the video that will summarize most of the points that have been discussing right now. This is a case of vitrectomized fluid-filled eye. You can see some remnants of the silicone oil, emulsified silicone oil in the anterior chamber under the dome of the cornea. It's quite common to see some remnants of the silicone oil inside the anterior chamber. It can be easily removed by injection of the dispersive and cohesive OVD during the soft shell technique prior to rhexis formation. And again, because of the high incidence of opening of the posterior capsule, just keep the 3-piece IOL as a backup lens. And here, while executing the rhexis and trying to make the rhexis as large and still allow for the 3-piece IOL implantation in the sulcus, just in case we have open posterior capsule, and do the optic capture. So I'm trying here to keep my rhexis between 5 to 5.5 millimeter in diameter. So this is the sweet spot that we can do safe phacoemulsification and do optic capture just in case. I don't like to do hydrodissection in these cases. I treat it like a posterior polar cataract, do gentle hydrodelineation in multiple locations and make sure that the lens has been completely free. And before entering the anterior chamber, we have to minimize the bottle height to reduce the infusion and to counter the effect of hyper deep anterior chamber. As we can see, I'm lowering here the bottle height before entering the anterior chamber. Regards the phaco technique, we can employ any technique as the surgeon wish, but I prefer the quick chop technique with vertical chopping. You can see that now the nucleus is freely mobile within the lens capsule. And because I believe that the vertical chopping is the least stressful technique on the jeopardized zone. And again, we can lower the bottle height to make those fragments within the lens capsule more accessible. And once we have complete or done our chop, we can now raise the bottle height and we can retrieve those fragments from the lens capsule to the anterior chamber and do the phacoemulsification in the supracapsular plane. You can see here we have still some fluctuation of the anterior chamber despite reduction of the bottle height and reduction of the vacuum. We can, of course, use the technology now again, as I mentioned before, that I have set the vacuum here to around 380 millimeter mercury. This is the rise up of the vacuum, and then the vacuum will drop instantaneously, as you can see here, to 267 millimeter mercury before occlusion. And this adds to the stability and minimize the fluctuation and trampoline effect of the anterior chamber in this eye, because there is no counter pressure from the posterior segment of the eye. This eye is fluid filled and not silicone filled. Of course, we can, if you don't have this technology in your hands, you can lower the bottle height and do some sort of slow motion phaco, or you can just prolapse the whole nucleus inside the anterior chamber and do for your phacoemulsification with the protection of the corneal epithelium with the dispersive OVD. And you can see here, of course, just keep the 3-piece lens as a backup lens. We are not sure yet that we have an intact posterior capsule in this situation. And this is the last quadrant. We can raise the bottle height a little bit to facilitate or to improve the stability of the anterior chamber. I don't like to keep the anterior chamber flat while switching the instruments. And now I just inject dispersive OVD and then continue for the next step by irrigation aspiration of the cortex. And as expected, as you can see, this is a fibrous plaque. Central fibrous plaque may be interfering with the visual axis of this patient. This patient was single-eyed, by the way. So I'm trying to remove this fibrous plaque with the viscodissection. I failed. I'm trying to remove it mechanically with the forceps, with the rhexis forceps, but unfortunately, this turned into a break, because most probably because maybe iatrogenic, or maybe because the lens capsule is already jeopardized from the primary vitrectomy anyhow. We can just go forward and trying to convert this break into posterior rhexis. I'm not surprised by this complication because I have already a backup 3-piece lens in my hands. And I made my rhexis customized for sulcus implantation with doing the optic capture. Now I'm preparing for the lens to be implanted in the sulcus by injection of dispersive OVD between the anterior lens capsule and the iris, and implant the 3-piece lens inside the anterior chamber. And with the Coghlan hook or the Sinusky hook, we can bring each haptic one at a time to place it in the sulcus in the proper situation. in the proper position. As you can see, this is the leading and then trailing haptic. And this is the moment that I like them doing the optic capture. And as you can see, by doing the optic capture, the lens is pretty well centered and the rexis has been turned to elliptical in shape, denoting successful optic capture. Don't forget that most of these eyes are highly myopic eyes, and maybe they have a large wide diameter, and the sulcus sometimes is larger than the overall diameter of the 3-piece lens. So it's preferable to do the optic capture before a conclusion of the surgery. And sometimes these wounds in the main wound in these eyes are usually leaked, so it's preferable to do a single stitch 10-0 nylon suture to just close the main incision for a few days, that can be removed subsequently with no sequelae. I think I summarized most of the points that I want to discuss with this movie, and thank you very much. I'm open for the discussion.
Thank you, Dr. Ahmed. I believe also we'll postpone discussion because we have a lot of questions about all the topics, and we invite Dr. Yuri Taktai from St. Petersburg, who will give his experience about intermittent cataract.
Thank you very much. Thank you, Dr. Ahmed, for your introduction. Let me check. Can you see my screen?
Yes.
Yeah, thank you. So we will talk about the intermittent cataract and the surgery. So the surgical removal of the intermittent cataract presents several very special challenges for the surgeon, because the intermittent lens has begun a lost structural integrity due to the protein is denaturated, and the lens is becoming hydrated, and the pressure inside the crystalline lens is increasing, and anterior chamber shallowing, and the problem that if you just touch the capsule, and you can have a high risk to explosion. So how we can manage the intermittent cataract to avoid Argentinian flag syndrome, especially in mature and hypermature cataract with the intermittent material, and the anterior capsule may undergo degeneration with the deposit of the calcium and development of the central dense plaque. And this is the case with the very dense plaque in the central area. And we try to manage the capsule. We try to reduce the pressure. This is the manipulation with the capsule. We staining the capsule to better visualization, and we try to open, and you can see the capsule and the plaque are slightly separate. We remove the capsule very carefully, and this is the 360 degrees rexis, but the plaque still present. We reduce the capsule. And this is the just superficial part of the capsule, because the plaque and the other capsule are still present. And I just try to make the rotation of the nucleus, and you can see at 6 o'clock still the capsule present, and we have a tear, yes, in this area, and the rexis is not completed. So we just remove superficial part of the capsule, and this is the problem. If you try to remove the plaque with the ultrasound, it's not helpful because it's very elastic. You can see this is the try to remove with the ultrasound tip, just try to aspirate the plaque. Now it's not helpful at all. I activate the ultrasound. This is the torsional movement. It's not effective. So, and we remove by the scissors and by the forceps this plaque. We are going forward. This case full of the septrices, because the color of the lens look like the lens is a very rock, white, brown cataract, and we remove Remove the capsule. Still we have we try to use the chop technique, and suddenly you can see I aspirate the central area. The color in this case not indicate the nucleus presence, and the nucleus grade doesn't depend from the color. So it's very soft material, and you just aspirate the material with a torsional ultrasound, and you can see the same plaque on the posterior capsule. So we just remove the material, and at that time you should decide what to do with the posterior capsule, because it's not only the central plaque, the fibrosis is going to the periphery. You remove the material, and this is the fibrotic capsule. Try to remove the residual part of the nucleus. Just rotate and aspirate the peripheral cortex. The pupil is not so wide, but 4 millimeter and a half. This is absolutely enough. No need to enlarge. It's better don't touch any mechanical stretching of the pupil, damage the sphincter. So for sure, if you can manipulate with the small pupil, it's better than if you have some special device to enlargement. And you just look around behind the iris, and you can see the strong fibrotic tissue. Check residual cortex as well. This is the surprising at 12 o'clock. This is the last piece of the cortex. And we decide to remove this plaque and keep the posterior capsule intact. By the needle, we just separate the fibrotic tissue from the posterior capsule, polishing a little bit in the periphery. This is a traumatic case, traumatic cataract with inflammation and then capsule fibrosis, anterior posterior capsule fibrosis. So there is no material in the periphery, and now we can focus to the posterior capsule. We come to leave, we come to open the capsule by the normal way, like from the posterior axis, because the fibrotic tissue go to the periphery, so you come to control the opening, and we decide to remove the fibrotic tissue and try to separate them from the capsule. You can manipulate by the needle, just lift it up and slowly separate from the capsule. It's a very delicate procedure due to the capsule are very, very thin, especially for intermission case, it's more fragile, and this is a very lucky surgeon if you finish this without posterior capsule rupture. Fortunately for me, for this day, it was my day, so we just removed the fibrotic tissue from the capsule without any damage of the posterior capsule. And this is the final step. You can see the capsule is intact, and it's easily separated from the. We remove the. Okay. So for some cases, the surgical trauma can cause the intermission cataract, and this is the case 1 week after the corneal transplantation. I can see the crystalline lens is the cloudy and the intermission, and this is the result of the rapid hydration, the opacification of the lens. So the anterior chamber is very, very shallow, and the problem that the cornea graft very close to the capsule, so we should to manipulate under the viscoelastic to protect the corneal graft from the mechanical damage from the ultrasound or irrigation trauma. Separate the signifier, staining the capsule. Due to the absence of the red reflex, also one of the challenge to intermission cataract. And in this case, we just use Hylon 5, so very cohesive viscoelastic, and we start to open the capsule with the small rexes, and this is also one of the points how to keep the control during the rexes. You can enlarge the rexes in the later stage, or you can enlarge during this step. So there is no need to hydrate because it's already hydrated. You just rotate the nucleus, and usually the nucleus is not very rough, and you can aspirate it easily with a very, very low energy. You can aspirate the material. No need to choke, no need to groove in the material. Just stay in the central and aspirate the soft material. There is no problem. Just what is important with the very shallow chamber, so to reduce all your parameters, to reduce the vacuum and reduce the flow rate to keep the endothelial cells. So the most critical step for intermission cataract for sure is the rexis step. And there are several approaches how to improve the visualization, how to improve the control during this step. First, we should to compensate the high intradenticular pressure. So we should put more viscoelastic, try to avoid the manipulation through the main incision, the side forks, the prevalence, and we can also to reduce intradenticular pressure to remove the water from the capsule by the needle, by the cannon. I'll show you next slide the technique how to aspirate the anterior cortex and reduce the pressure inside the crystalline lens, and you can manage with the capsule by the normal way. You just paint in the capsule, penetrate by the needle, and aspirate the cortex. And this is also the case of intermission. But in this case, this age-related cataract, the nucleus is not soft. This is a small but very rough nucleus. We also penetrate the capsule by the needle. We try to aspirate the soft material, and it's like the Morganian cataract. You will see the red reflex appeared, the material disappeared, and this is a very small residual nucleus at the end, and also fibrotic capsule. And for this case, the rex is not easy, but the capsule is very fibrotic and it's very compromised for the zonulus. You can see destruction, damage some zonulus, and finally we have a problem with the capsule formix and with the interim CTI in this case. I'll show you this step. This is the step of the nucleus removal. Just go forward a little bit. Oh, sorry. Yeah, and you can see this is the problem with the capsular formix, and the CTI is very helpful for this case. Just put the capsule tension ring to reestablish the capsule contour. Cheng already explained that the capsule, even if you put the CPR posterior capsule, are very floppy, and it's the high risk of damage of the capsule. In this case, we have the same problem with the posterior capsule. I'll show you at the end. This is the capsule defect, and we also try to round it, this defect, and perform the primary rexis just to keep the capsule back for in the back implantation.
Sorry, Dr. Yuri, but we have 2 minutes left only.
It's okay, we will finish. So this is the other option how to manage intermittent cataract. You can penetrate the capsule and create a very, very small rexis in the periphery. And this opening can be enlarged in the later stage. Just remove the small part of the capsule and aspirate the material by the cannula, so reduce the pressure inside the bag, and you can easily manipulate later on. So this is the trick how to manage the intermission case. And for conclusion, the intermission cataract presents some special, very special surgical challenge that frequently has a successful outcome with advanced staining of capsule and increasing the automatic techniques. So we should use a special viscoelastic, special forceps, and even if Argentine flex syndrome is present, we can keep control and put the lens in the back. So this is the final slide. Thank you very much.
Thank you. Thank you, Dr. Yuri. Very interesting presentation. Now, Dr. Mohammed Hisham Ali, Director of Maghrabi Hospital Dubai and glaucoma and cataract surgeon, will give us a talk about cataract surgery in phacoemorphic glaucoma. Dr. Mohammed Hisham. Dr. Yuri,
yes,
can you please?
Here, yes. Actually, yeah, I will share my screen.
I hope is it the same topic, or you would?
No, actually, because it's the intermittent cataract is just like the phacoemorphic. So I was preparing, and then I found out this very nice case. Is it? Here it is. This. Can you see my slides?
No, still not.
Okay.
Did you, Dr. Yuri? Yeah, it's okay.
Okay. Okay, I will go on. So because of the intermittent cataract is just like the phacoemorphic cataract. So when I was preparing the talk, I found out this very nice case. Actually, it's a lens-induced angle closure glaucoma. It's not cataractus, but it's a very nice case. Here it is. So this is just like a case presentation, very informative for me and for the others, I hope. This patient was referred to me by colleagues. She's a lady of 32 years old. She had a history of heart disease, and she had thyroid problems. So she was taking thyroxine, 75 milligram. She was taking Topamax for migraine. And then she had some sudden attack of bilateral eye pain, foggy vision, tearing, intolerance to light with severe redness. Her doctor was found out that her IOP was in the 50s with a very, very shallow anterior chamber.
Both eyes.
Both eyes. So she was given Cosopt, Alphagan, and she said that the IOP, as I told you before, the pressure before the treatment was in her 50s. Her glasses before the attack was just astigmatic. She's plano sphere, but nearly astigmatic. When I saw her, her vision was counting finger, 1.5 meter in one eye and 2400 in the other eye. The cornea thickness was normal. With the pressure and with the Diamox, which was taken, their pressure was 23 and 20 millimeter, but very shallow anterior chamber still. and she had ciliary injection. The cup disc was actually normal. She didn't have, and this is her fundus photography by the Optus. You can see the cupping is not that much, so she's not a chronic actually glaucoma. The OCT, the anterior segment OCT, found out that all the complex of the lens and the iris was pushed forward in both eyes. So it's similar. It's actually symmetrical in both eyes. The visual field was done. It's a diffuse visual field loss, so it's nothing special for the glaucoma. This is her right eye. This is her left eye. It's diffuse loss of the visual field. We cannot interpret it to the glaucoma. So the diagnosis that I made was that she had a chorioretinal effusion from the use of Topamax. And this is actually one of the complications that can happen to Topamax. It can cause bilateral lens iris complex forward displacement. So what did we do? We stopped the Topamax. We gave her prednisolone just to quieten the eye, continue on the Diamox acetazolamide. We gave her a cycloplegic. And this was the second day. You can see how she's high myope now with the astigmatism that she has. But the patient felt better. However, after a few days, the refraction went back to nearly her normal refraction before. And the AC become deeper now. Refraction went to back. The pressure, of course, with the Diamox and everything, was 8 and 11. We advised to stop the alpha-GAN and remeasured after 1 week. The patient was even without with the COSOPT only, the IOP was 7 millimeter mercury in both eyes. The vision with her own correction was 20/20. So we advised to stop the COSOPT and remeasure it after 1 week. She was fine, and after 1 week she was fine. So as a discussion, the complications of Topamax is acute bilateral angle closure glaucoma and acute happening of myopia. And if we discontinue the Topamax, everything will go back to normal, but the patient has to be warned against using it again. The patient may still have to have glaucoma medications, but we have to be careful. So we have to be careful when withdrawing these medications. Peripheral iridotomy in these cases are useless. We cannot, it's not required. This patient is not an angle closure glaucoma. This is an, let's say, temporary angle closure, temporary phacoomorphic glaucoma. UBM is very helpful if we have the shallow anterior chamber. So macular striae may happen with the Topamax. This is complication that can happen with the Topamax to happen macular striae, which is usually temporal. The differential diagnosis of this case are malignant glaucoma, pupillary block glaucoma, suprachoroidal hemorrhage, serous chorioretinal effusion. The differentiation, how to differentiate between them is when in the malignant glaucoma, the pressure will be elevated most of the time, while in the suprachoroidal and choroidal effusion, the pressure will be low. The anterior chamber depths in malignant glaucoma will be very shallow, all over, central and peripheral. In the suprachoroidal, the pupillary block, the central part will be deep because there is a curve in the of the iris bone base, so it will be deeper central and flat periphery. The egg resolves only the pupillary block, but doesn't resolve the other kind of glaucomas. Fundus examination, of course, we can find we will find a bullous choroidal effusion with the colors in the hemorrhage and the choroidal detachment, while in the malignant glaucoma and the pupillary block, it will be flat. UBM is very helpful in the first in the malignant glaucoma pupillary block, but of course we cannot it cannot reach the choroidal effusion and the hemorrhage. And thank you so much for just listening to me.
Thank you, Dr. Mohammed Hisham. Thank you very much. Interesting, very interesting. Usually we have always facing unilateral angle closure glaucoma, but this is a case of bilateral because of systemic region. So you finish before the time. I hope that we have time later on for discussion. Now the last talk by Dr. Ahmad Musallam, head of department in Ras Al Khaimah Hospital, and he will give his experience or his way of shopping anterior posterior phaco shop in extreme eyes. Please, Dr. Ahmad. Dr. Ahmad, I think you are mute. Dr. Ahmad, can you unmute your, please, Dr. Ahmad, you are mute. Dr. Ahmad, can you hear me? You are mute, Dr. Ahmad. Dina, can you unmute Dr. Ahmad, please? Dr. Ahmad Musallam.
I think she unmuted me instead of Dr. Ahmed.
And it can easily be taken care by intravenous epinephrine. So there are various indications like.
Okay, sorry. You are hearing me now?
Yes, we're hearing you.
Yeah, you saw my slides? It's not working. Okay. Okay, sorry for the losing time. Thank you, Dr. Imad. Thank you, everybody. My talk today is posterior anterior chopping technique for phacoemulsification. The most present phaco chop technique perform anterior posterior chopping using sharp vertical choppers. In contrast, back is posterior anterior chopping using the flat curved and blunt Koch spatula. Difference from a regular phaco chop is only the direction of chopping. All other phaco parameters and rest of surgical steps remain the same. I will show you the spatula, what we are using. It's Koch spatula. It's very humble spatula available in the market. It contains from flat two surfaces, flat surface and lateral edge. This slide showing spatula position under the nucleus with soft cataract, the flat surface facing the nucleus, with moderate and hard nucleus, lateral edge facing the nucleus. We prepared animation video just to make this technique more easier to understand. We have top view and wide side view. Top view showing how inserting the phaco tip in the middle of the nucleus, and under high vacuum and occlusion, we are tilting and lifting the nucleus. And side view showing how the spatula inserting between the nucleus and epinucleus, and how we are performing the first chop. This is let us to see how it's this technique coming with the real patients with moderate cataract. Sorry. With the moderate cataract, as you see how we are inserting the spatula under the nucleus, and how we are performing first hemisphere chopping, dividing to small pieces and make it easier for emulsification. And as you see, second hemisphere, we are tilting and moving it to the center, and the same way we are using the spatula. It's curved and very safe to use it during the phacoemulsification. Now epinucleus removal. As you see the spatula, position of the spatula between the phaco tip and the posterior capsule to protect the posterior capsule. With more harder nucleus, as you see the same way we are using to perform first chop and first hemisphere sub-chop. And as you see, we are using the spatula to crushing the material, the hard material, and make it easier for emulsification to minimize ultrasound energy. And you see all small fragments we should to remove first. Second hemisphere, as you see with the spatula, how easy to divide it to 2 pieces, and how we are crushing the material with the flat surface to make it easier and smaller for phacoemulsification. And as you see all the time, position of the spatula between the phaco tip and the posterior capsule to avoid any touching from the posterior capsule and between the posterior capsule and phaco tip with epinucleus removal. And again, you see the position of the spatula, how is working well to protect the posterior capsule. And this is giving chance to work faster and to make flow rate faster during phacoemulsification. And as you see exactly how the lateral face facing to protect the capsule. With the, again, very hard cataract, first chop, again, how it's easy performing using the lateral edge of the spatula. And as you see how we are crushing the phaco, the material to make it smaller and smaller for easier emulsification. And as you see, all the free fragments should be aspirated first to avoid any damage to the posterior capsule during the rotating the nucleus. As you see again, the same way we are using the spatula, it's crushing the material, make it smaller, saving ultrasound, especially with the patient with hard cataract, to avoid any damage to the endothelium of the cornea. As you see, finish with the first hemisphere. All the small fragments should be aspirated also. Little rotation. And dealing with the second hemisphere as the first hemisphere. Very easy. And dividing all the big material to the small pieces to easier for emulsification. As you see how the spatula all the time, it's between the phaco tip and the posterior capsule, avoiding any rupture to the posterior capsule, because you know during our work we have fluctuation of the posterior capsule, and this is the spatula. It's not sharp, don't have any sharp end to damage the posterior capsule, and the curve is the same curve as the posterior capsule. And when we have any fluctuation, it's hitting the flat surface of the spatula, and it's very safe spatula to work with during phacoemulsification. Again, with the epinucleus removal, you see the position of the spatula tracking all the time between the phaco tip and posterior capsule. This, as you see, the patient without any epinucleus and cortex, it's very we don't have any protection now for the posterior capsule. Only the spatula working as the protector for the posterior capsule. Here also easy to perform first chop as previous cases, and how we are crushing the material to make it easy for emulsification. Last case I have with the weak zenules. Here we are working very slowly, like slow motion, because we don't need any pressure to the weak zenules. And as you see, very easy to perform first chop. And again, the same way what we are doing, dividing first hemisphere to small pieces, to small fragments to make it easier for aspiration. Here we need to be careful because we have bad zenules, weak zenules, and we don't need any pressure. We need to take all the hard material to the center of the pupil and to aspirate it piece by piece, we need to be gentle in this surgery. Again, second hemisphere the same, and we are holding and moving the nucleus to the center, far away from the zenules to minimize the pressure to the weak zenules. As you see, with the second hemisphere, slowly aspirating and using the spatula to divide the pieces to make it easier and to aspirate it very easily. Next slide, it will be slow motion, I think, and have a time, Dr. Imad.
Yes.
Next slide. What we have, I have before some question about how we are inserting safely the spatula, and we just make a video with slow motion just to show you exactly how two hands working together to create enough space to insert the spatula in the place. And as you see, how we are performing and how we are keeping the epinucleus, moving the epinucleus material with this spatula just to create more protection to the posterior capsule. And as you see, we called it manual dissection, which means we are just moving with this spatula the epinucleus. And as you see how we are inserting the phaco-tip, and we are moving the nucleus a little bit, and in the same moment we are moving our spatula under the nucleus, and we are performing first chop. It's easy coming. It's a very safe spatula. It's don't have any sharp edges to damage the capsule or iris or and again this next video showing the same way what we are doing, all our technique, what we are working the same way. I want to stop this video to back again to save your time.
So the position of the side port is opposite the main incision,
yeah,
right?
Should be minimum 90 degree. It means if we are main incision in the 9 o'clock, the side port should be in the 10 o'clock. It means we have relaxing hands to deal with this technique.
And we can call this shopping. We can call the shopping backward shopping. Dr.
Yeah, maybe we can name it like that, but this is the summary of our back technique, and you saw all the steps what we are doing during our surgery. Advantage, as you saw, we can use this technique with all kinds of cataracts. And as you see, we using this technique successfully with the weak sinules. No need special very big pupil size to perform this technique. About the capsulorhexis also, because we are working in the center of the pupil, also we can manage with small capsulorhexis. This is also very important tool for myopia and post-vitrectomy eyes, because just we are holding the lens and we are making the anterior chamber. I mean, we are holding the nucleus and in the level what we need, because we are holding it. The next slide showing BCR during this technique. In the last 714 cases, the BCR rate during the nucleus removal with back technique, it's 0.7%. It's mean 5 cases in 714 surgeries. Thank you for your kind attention.
Thank you very much, Dr. Ahmed. It's a very interesting way of shopping. And I think we have time, maybe 10 minutes or less for discussion. And for the first presentation of Dr. David Chang, he presented a very important maneuver in managing of very shallow anterior chamber, vitreous step. I want to discuss this point with our professors like Dr. Ahmed Assaf and Dr. Yuri. Are you doing the same, Dr. Ahmed Assaf, are you doing this way?
Yes, I'm doing this, but I try to avoid it as much as I can, because it carried the high risk for injuring the posterior capsule. And I did it myself iatrogenically sometimes, even if you direct the retractor or the spatula or the MBR toward the optic nerve, because these are very crowded eye and the anatomy inside the eye is bizarre and with a large lens. So there is high possibility to injure the lens while doing the vitreous step. So I'm doing this technique, but I'm trying to or get around this by mannitol, intravenous mannitol. I'm trying to do some mechanical pressure just before the surgery to reduce the pressure inside the eye, use the high viscosity OVD like the Helon 5 if available, if everything measure failed. So, or probably if I anticipate that these measures will not do the job, I will do, of course, vitreous step.
Very nice. What do you think, Dr. Yuri?
Dr. Mahdi, I lost the beginning of the presentation of the first case, so there is no discussion from my side.
Okay.
I connected a bit later on, sorry.
Okay. Dr. Chang, do you have any comment on what Dr. Ahmed Assaf said?
Yeah, no, I think these are extreme cases, and you just have to keep in mind that this is not what you normally do with a pars plana anterior vitrectomy, where we tend to go anteriorly, aim for where the lens is. And I think if you do go straight back toward the nerve, you can also turn the cutting port away from the lens. You should be able to avoid it because you're really coming in at the level, really at the lenticular plane. You're really going through the sulcus. But, this is clearly something not everyone will be comfortable with. If you've done pars plana anterior vitrectomy, it's a little bit easier. I think that the other approach would be to simply do a manual small incision extra cap. And it's just the problem is that sometimes, as I said, these eyes are a little more prone, as was mentioned, by Dr. Hafez, that, suprachoroidal hemorrhage is a bit more of a risk, or infusion. So being able to keep a small incision is always nice.
Thank you very much. I have also a question to, I think this is a question to Dr. Yuri from the participants. do you think the usage, Dr. Yuri, for in case of milky cataract, do you think the usage of negative pressure and do aspiration increase the dislocation of capsule comparable with that is done classically? Dr. Yuri, please.
No, the step when we try to aspirate the material before we open it, the capsule, this is just to reduce the pressure and compensate the pressure in the anterior chamber and interlenticular pressure. In case if it's inside the capsule back, the pressure is very high and you just touch the capsule, this is a high risk for explosion. And the Argentinian reflex syndrome is one of the problems which happened in the early stage of the cataract removal. So we try to reduce the pressure first, and then we try to open the capsule.
Thank you, Dr.
And it's very, very helpful. So you can manage by the different manner. You can start with the opening with the small rexes, or you can penetrate by the needle and aspirate by the same needle, or you can create very small rexes and aspirate by the cannula. So it doesn't matter what technique do you use, but the principle, reduce interlenticular pressure.
Yes, thank you very much. We have two glaucoma surgeons in our session, Dr. Ali Hafiz and Dr. Muhammad Hisham. I invite them if they have any discussion with their presentations. Dr. Ali?
Oh, yes. I mean, again, I'm gonna highlight the now trend for tackling cataract and angle closure glaucoma with cataract extraction without going into filtering procedures. More and more we are doing that now. The two problems I kind of mentioned that tend to follow angle closure glaucoma are the persistent or residual peripheral synechiae, as well as the persistence of the iris, plateau iris configuration. One of them, the first, is dealt with using goniosynechiolysis. The second is dealt with using endocyclophotocoagulation. This is basically the approach we tend to take for such cases. The second point is what I've mentioned about the Eagle study and clear lens extraction. And I'm still not at a comfortable level to use to extract clear lenses to treat glaucoma. I think we need to kind of reapply that study on different populations and on different stages of glaucoma before we kind of use it. And but it is a step, and this is how research is done, one step at a time.
Thank you very much, Dr. Ali. Thank you for everybody shared in this session. It was very informative and interesting, and because of the time, we have to conclude it now.
We have a, sorry, Dr.
Yes.
Ahmad, we have a company symposium for Sophi.
Yes, we'll start now this symposium, Sophi Symposium. Please, Dr. Roger. Can you unmute Dr. Roger?
Yes, Dr. Matet. Can I just introduce the Dr. Roger first, because we have a communication with before the Sophi machine will be introduced on the market. We have a short introduction, and I would like to use this opportunity to introduce this Sophi machine. It's a new platform from the Switzerland, and the Roger, he's the chief of the sales manager of the company, of the AG, and Roger, please, what is the innovation you prepare for the surgeons? Because not every year we receive the new innovation platform.
Yep.
What the news from your side, please? Can you make a introduction?
Well, good evening, ladies and gentlemen. Thank you, Dr. Yuri, for the introduction. I would like to use also this opportunity to thank the panel and the Mar Vision for enabling me today to present at the CASME ophthalmology conference, international conference. In the next minutes, I would like to use this opportunity to introduce our new phaco system, Sophi. My name is Roger Weber, and I'm the head of sales at the FIS AG. Sophi is the brand of our device and stands for Swiss Ophthalmology Innovation. Well, who is Sophi? Sophi is not an evolution. It is but a revolution. It's not a simple adjustment of an existing technology. It is meant to be a complete innovation. We spent many years developing the device, and I'm going to share with you some of the interesting aspects of this machine. But most important is that the smallest details, which have been designed with a very specific goal, is to make the work of the ophthalmologist and the surgical team more mobile, simpler, safer, and finally more efficient. Well, I'm going to show you here on this slide, there are, you see two models, but in fact are three. The Sophi Premium and the Sophi Eco are two variants for more customized solution, matching with the doctor requirement. And the Sophi A is, let's say, the small version, the tabletop device. However, all these three systems feature almost similar technology when it comes to simplicity and safety. And I'm going to move here to show you the Sophi A, which is a portable device. It's easy to carry with a trolley. But mainly, if we want to focus on the three pillars of the Sophi, it's the mobility, simplicity, safety. Due to the shortage of time, I'm going to share with you some aspects related to the mobility, and especially, which is most important for you, is the safety. Well, the first impact you see on the machine is that it is the first battery-powered phaco device. You can work completely independent with the integrated battery throughout the surgery day without any need of electrical supply. Also, the purpose is to eliminate all the cables and the tubes, which are very often disturbing you in your daily routine. And therefore, we have also eliminated the cable, the tubes for the compressor because of the air supply, because we have integrated compressor for the venturi and the anterior vitrector. Moreover, as part of the mobility and the flexibility to position the machine at any place you want, gives you that flexibility to position and to work at your convenience. And last but not least is we have the wireless foot pedal with the induction charging. So even here, you don't need a cable to charge the foot pedal. So this is an interesting aspect about the mobility, but I think I'm going to focus in the next minutes mainly on the safety aspect, and in particular, the triple pump fluidics. This is something really unique here because Sophi feature 3 pump system in one device. And the first pump system is the IOP control pump, which is meant to be for stabilizing the infusion pressure in order to maintain the anterior chamber stability of the eye. There we have also the peristaltic pump to control the flow and the vacuum, and a very interesting pump, venturi pump, we call clean venturi pump, which protects against any contamination with the patient's eye fluidics. I'll come to that in a minute. There you see a very lean cassette, but the complexity lies in the system. So in this cassette, there are number of sensors, valves, membrane, barcodes, and here you have all 3 pumps in one. So this is what you see here. The front part is the peristaltic and the active infusion, and the other part is the venturi. So coming to the IOP control pump, I'm going to spend a few minutes here. The new solution we have in our Sophi is that the pump usually compared with the gravity pole, which is very often when you use high values of vacuum, it might lead to instabilities of the anterior chamber. We have solved this by integrating the IOP pump, which is calculating and compensating the loss in pressure in the infusion tubing as well as the irrigation aspiration tube. So as soon as the pressure drops in the eye, the IOP control, which is a roller pump, which is nothing else than a second peristaltic pump, increase its rotation and therefore the irrigation flow to keep the IOP stable. So the IOP control pump is extremely fast, and therefore it maintains your requested IOP in the eye constant throughout the surgery. How is the mechanism of the IOP control pump? So when the IOP drops in the eye, the pressure due to occlusion break, for example, the pressure drops in the irrigation tubing. And in the cassette, we have a sensor, built-in sensor, which is where the IOP drops as well. And automatically it gives the order to the IOP control pump to rotate faster, to go at full speed in order to maintain the IOP. And the whole process takes only a few milliseconds. So the second pump we mentioned is the standard peristaltic pump for vacuum and flow control of aspiration. But also nowadays, very interesting is to highlight that we have also with the clean Venturi pump, as you can see on that slide, there is a blue membrane, and that separates the patient liquids from the external air supply or the external air coming from the compressor. And therefore, there is no risk for contamination. Because the patient liquids is all the time separated from that compressed air. And therefore, there is no risk that compressed air, which is usually unlike other machines, touching this patient liquid and if somehow is blown into the machine or into the surgical environment. So that gives that protection for the surgical stuff too. So these are actually my few words I wanted to share about the Sophi. There are, of course, certainly much more to know about, and therefore I would like to invite you to visit our website, www.sophi.info, to learn more about our new phaco generation. Thank you very much for listening. Thank you for inviting me again to this panel, and wish you a nice evening. And if you have any question, please.
Thank you, Dr. Roger. Dr. Yuri, I believe you use already this machine. Can you unmute Dr. Yuri, please? Dr. Yuri, you are mute.
Sorry, Dr. Imad, this machine is available in Arab Emirates?
Yes, this machine is going to be available in the UAE in next month. We've already sold this machine. We're already available in many markets across Europe, Middle East, mainly Asia Pacific, and a couple of Middle Eastern countries. But the machine is coming next month to Dubai.
I mean, it's as a demo. Just we can use it to see how it's look
Yes,
like
exactly.
fine. Everything's okay, but we need just to try it.
Sure.
Absolutely, that's the reason why we are bringing it over, of course.
Yeah. Dr. Yuri, you were mute when we ask you about your experience with this machine. You were mute.
Dr. Martin, still I have not experienced. I just have an introduction from the Roger, and I won't taste the machine. I won't try. Due to the stability of the anterior chamber, this is the new top, and we have some very advanced technology from Alcon with the active sentry with the same reason, so we can reduce intraocular pressure and stabilize the anterior chamber at the same time. So it is a very, very important step. So, and it's very interesting how this pump for the irrigation line can compensate the post-occlusion surge, and can we reduce the intraocular pressure during surgery to the normal range. Most of the doctors perform the surgery today on the rock eye, the very firm eye, and it's not good for the blood flow, circulation, and the central retinopathy. And it's a very, very interesting technical idea how to improve the stability. So we will see in the near future.
Thank you. Thank you very much, Dr. Mohammed.
Can we conclude, please? Because we are already behind the time. Sorry.
Thank you. Yeah. Thank you very much, everybody.
Thank you very much.
For the speakers and
Thank you.
participants.
Thank you.
Thank you very much.
See you in the next occasion.
Thank
All
you.
the best for all, but.
Inshallah.
Bye-bye.